Hello everyone. So let us study today about diabetes complicating pregnancy. This is me, Dr. TSR. So definitions of GDM. It is defined as carbohydrate intolerance of variable severity with the onset or first recognition during present pregnancy. The definition is important. They will ask in Viva. What is GDM? GDM is carbohydrate intolerance of variable severity with the onset or first recognition during present pregnancy. So why pregnancy is diabetogenic? Because of insulin resistance caused by the hormones, that is like human placental lactogen, increased production of cortisol, estriol and progesterone, and increased insulin destruction by the kidney and production of enzymes like placental insulinase. So when there is insulin resistance, there occurs increased lipolysis. The mother uses fat for her calorie needs and gives glucose for the fetus. There is change in gluconeogenesis. The fetus uses preferentially alanine and other amino acids and deprives the mother of major glucogenic source. So in pregnancy there is facilitated anabolism and accelerated starvation. This is important. In pregnancy there is facilitated anabolism and accelerated starvation. So high risk factors for GDM: family history of diabetic mellitus, obesity, older age group, previous big baby, anomalous fetus, Indian, previous history of IUD or stillbirth, polyhydramnios, previous history of GDM, PCOD or metabolic syndrome, present pregnancy, repeated UTI, monilial infections, polyhydramnios and macrosomia. Screening test, we do oral glucose challenge test is done around 24 to 28 weeks. OGCT is done at first visit. If negative, again 28 and 32 to 34 weeks. It is actually OGTT, glucose tolerance test we will do. That is DIPSI. Challenging test is as per ACOG criteria, that is the screening test. I think DIPSI will come next. First it is the challenging test where you give 50 gram of glucose. After 1 hour check the blood glucose. The value is of more than 140 mg per dl. That means it is GDM. So you will give 50 gram and after 1 hour you will check. If it is more than 140 mg per dl, you will proceed with OGTT, oral glucose tolerance test. Nowadays they are using cutoff of 130. So after that you have to follow it with oral GTT to confirm GDM. So the GTT, oral glucose tolerance test, is a diagnostic test. It is GCT is going to be screening test. It has to be a normal diet has to be taken on the previous day, and you should ask the mother to come in fasting. That is 8 to 10 hour of fasting. You will take fasting, then 1 hour, 2 hour you will take. So as per WHO criteria, give 75 gram of glucose in 200 ml of water, and the venous blood is taken after 2 hours. GDM, if FBS is more than 110 and 2 hour is more than 140. So when you say overt is when FBS is more than 126 and any random blood sugar level more than 200 and HbA1c level is more than 6.5%. Okay, so this is about overt diabetic mellitus. So in India what we prefer is one step test, that is diabetes in pregnancy study group of India criteria, done at 24 to 28 weeks. Actually preferred is first visit 24 to 28 weeks and again at third trimester 34 to 36 weeks. Irrespective of the any previous meal, 75 gram of glucose is given mixed with 300 ml of water, and you will check the blood sugar after 2 hours. If the value is less than 140 mg per dl, it is considered normal. If it is more than 140, it is GDM. 120 to 140 is impaired glucose tolerance. So investigations for GDM: urine for albumin sugar deposits culture sensitivity, and you look for HbA1c glycemic profile. So HbA1c is glycosylated hemoglobin, gives an idea about how is the glycemic control over the last 3 months, and normal should be less than 6. We should do OGTT or glycemic profile, and we'll do blood urea, serum creatinine, uric acid. Can be associated with preeclampsia. And fundus examination done in overt DM, GDM associated with preeclampsia, and thyroid function test. Thyroid dysfunction can coexist. So ultrasound, early scan, targeted scan, and growth scan. To detect macrosomia, we will go for abdominal circumference of more than 95th percentile. And truncal skin fat, skin thickness above the scapula also measured. There is large placenta also. And Doppler as an routine investigation. So complications of GDM, first trimester it can go for diabetic embryopathy, abortion. First trimester hyperemesis gravidarum, and infection can precipitate ketoacidosis. Then during second trimester there can be increased risk of congenital anomalies. And during third trimester, polyhydramnios seen in 10% of GDM, that is amniotic fluid of more than 2 liter, because of fetal polyuria, hyperosmosis, hyperglycemia. So when there is polyhydramnios, there is increased risk of abruption, preterm labor, or postpartum hemorrhage. Then increased risk of preeclampsia, that is 25%. Increased risk for post-operative infection, and even during antepartum vaginal candidiasis, UTI, endometritis, wound infection, purpural sepsis, and increase in the risk of instrumental delivery and LACS rates. Fetal complications are macrosomia, shoulder dystocia, again obstetrics nightmare, and unexplained fetal death. There is 4 to 8 fold increase in the risk of congenital anomalies, that is caudal regression syndrome, sacral agenesis, heart diseases like AST, VST, transposition of great arteries, neural tube defect, renal defect, GI defect. Neonatal complications are respiratory distress syndrome, hyperbilirubinemia, because insulin is there. Insulin is not a friend of surfactant. Insulin will inhibit the synthesis of surfactant. So there is respiratory distress syndrome. And there is increase in the production of RBCs. There is polycythemia. When there is polycythemia, there will be increase in the level of hyperbilirubinemia, bilirubin. Okay. So during antenatal period, mother is the supplier for glucose. When baby delivers, there is no supplier, so hypoglycemia. So all electrolyte imbalances, there is hypocalcemia, and the temperature, hypothermia, temperature control is not there. Because of this polycythemia, there is hyperviscosity of the blood, increased erythropoiesis, which in turn causes renal vein thrombosis and necrotizing enterocolitis. And in heart, we get reversible hypertrophic cardiomyopathy. Management. So management includes antenatal monitoring, so strict glycemic control with diet, exercise or insulin. Medical nutrition therapy with exercise. Target is FBS less than 90 and ppbs less than 120 mg per dl. Every 2 weeks I have to repeat if it is on MNT. Weight gain is to be optimal. Rule out preeclampsia, polyhydramnios and macrosomia. Ultrasound, dating scan, NT scan and anomaly scan 18 to 22 weeks to rule out major malformation. Fetal echocardiography to rule out cardiac AST, VST and TGA. Third trimester for the growth, accelerated growth or abdominal circumference, head circumference, rule out polyhydramnios. Do antepartum fetal surveillance. Daily fetal movement count is must. There is modified biophysical profile. Then good time to delivery is after 38 weeks. Should get good neonatal care and counseling for the future pregnancy. GDM and MNT delivered 40 weeks on insulin with the complications at 38 weeks. Pre-diabetes complicating pregnancy again delivered by 38 weeks. Can give steroids for the lung maturity. On the day of induction, withhold the insulin. Glucose has to be checked every 2 hours and IV fluid has to be given. Risk of IUD has to be explained. If there is good glycemic control, IUD risk is less. Not beyond 38 weeks because there is our enemy, that is IUD. So vaginal delivery is not a contraindication. So if there is no maternal fetal complication, average size baby, there is no CPD, good favorable cervix, good Bishop score, vaginal delivery. Partogram is to monitor the labor, and LSCS is mainly because of fetal distress, prolonged labor or macrosomia. During labor, vomit the insulin. Regular insulin can be given as infusion 1 unit per hour. We have to maintain the sugar level between 90 to 100 mg and do check the sugar level every 2 hours. If there is macrosomia, CPD, bad obstetric history, we prefer elective C-section. Postpartum follow-up, after 6 weeks, they have to repeat again OGTT at 6 to 12 weeks postpartum. Because after the delivery, whatever the insulinogenic, diabetogenic hormones, that is human placental lactogen, cortisol, estriol, progesterone, all of this will decrease. So the level of insulin need is decreased and the dose is decreased in overt diabetes. Especially in GDM, it may be absent also. Postpartum, 95% of GDM return to the normal glucose tolerance and require no further insulin in postpartum period. So we have to check the blood sugars before the discharge. On third postnatal or postoperative day, do FBS and PPBS. So my key points in this class. What is the definition of GDM? It is a carbohydrate intolerance of varying severity recognized first time during the pregnancy. Pregnancy is a diabetogenic state because of physiological insulin resistant, and antenatal screening has to be done at first visit. If negative at 24 to 28 weeks. Tight glycemic control has to be maintained, FBS less than 90, PPBS less than 120. Fetal surveillance for fetal well-being and to predict the macrosomia and polyhydramnios. With MNT and exercise, optimal glucose control can be obtained. Those who require insulin with the complication has to deliver at the earliest, and insulin requirement falls sharply after the delivery.